Hi, my name is Mike Pishfine. I'm a GI medical oncologist at Johns Hopkins University, and it's my pleasure to be a moderator here for a GI Oncology Tumor Board. And I'd like to go around and introduce the panel. I'll start with Dr. Zev Weinberg from UCLA.
Hi, my name is Dr. Zev Weinberg. I am a GI medical oncologist at UCLA, Los Angeles, California. Nice to be here.
And then from Emory, Dr. Pritesh Patel.
Hello, Pritesh Patel, Associate Professor of Radiation Oncology, GI Radiation Oncology at Emory.
From Memorial Sloan Kettering, Dr. Martin Weiser.
Hi, I'm Dr. Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
And finally, from Washington University in St. Louis, Dr. Carrie Siegel.
Hello, my name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Well, thank you all for joining us. It's going to be some very interesting discussion about some exceptional cases, and I think we should go ahead and dive right into it. This is a 53-year-old patient with cholangiocarcinoma, completed surgery and adjuvant therapy, but then developed recurrent disease. And what would be the treatment plan recommendation for that patient? So as far as how the patient initially presented, they presented with scleral icterus, abdominal pain, weight loss, and fever. The performance status was an ECOG of 2, and they weren't feeling great. They had a medical history of diabetes and hyperlipidemia, but no tobacco, alcohol, or drug use, and there was really no family history of cancers. As far as the oncologic history, the patient had an elevated CA19-9 and slightly elevated CEA. The abdominal ultrasound showed mild splenomegaly, a contracted gallbladder, and a few echogenic areas noted in the common bile duct. The patient then had a triphasic CT scan that showed mild intrahepatic and extrahepatic biliary ductal dilatation with the stents in place, radiographically a T1N1M0. The patient had an endoscopic retrograde cholangiopancreatography looking into the bile duct, or we also call an ERCP, where the 2 plastic stents were inserted, but brushings of the bile duct did not show any malignant cells. And then finally, brushings were positive for malignant cells from the common bile duct in a couple months later in September 2019. So Dr. Siegel, here's the ultrasound imaging.
You can see here is a sagittal view, and the common bile duct is the tubular structure with the calipers on it, and it's dilated. On this particular image, it doesn't look like there's any thickening of it, and I don't see any masses or echogenic foci within it. And the differential for a dilated common bile duct, as we all know, is extensive. So I don't think this image optimally shows the tumor under discussion.
Gotcha. And so actually, along those lines, what diagnostic imaging do you really consider essential in a patient with a potentially operable cholangiocarcinoma?
Well, there's basically 2 options, which would be multi-phase CT and multi-phase MR. There's advantages to both, but what we really want are non-contrast arterial and then more portal venous or parenchymal phase imaging. We want to get an excellent look at all the vascular anatomy, the celiac, the SMA, the hepatic artery. We want to look for any abnormalities in terms of branch anatomy, either off the aorta or in the liver, lymph nodes in the area, involvement of the duodenum. I prefer MR to CT, and the reason why is we get a little bit more information with the MR than the CT. When we do a CT, our pancreatic protocol is often non-contrast arterial and portal venous phase imaging. But with MR, we can scan again and again, because each scan does not give us any, or certainly any additional radiation. So a lot of times an MR protocol will have 4 or 5 sequences through the upper abdomen, both non-con, early arterial, late arterial, portal venous, and delayed. So we get a little more information there because we can scan more times. And the diffusion imaging is very valuable. A lot of times the radiologist will put the diffusion image up next to a post-contrast or a T2 weighted image and just go slice by slice by slice, looking for subtle areas of diffusion restriction. And it's very sensitive for picking up subtle liver metastases, peritoneal deposits. So I mildly prefer MR, but I think both are good.
Excellent, thank you. Following up with the oncologic history, the patient did have an MRI and MRCP in February 2020 that showed mild nonspecific mural thickening of the common hepatic duct at the level of the confluence, showing post-contrast enhancement, but no exophytic measurable mass was seen. In September 2020, the patient underwent a cholecystectomy, with lymph node biopsies, showing a moderately differentiated adenocarcinoma. The lymph nodes locally were positive for metastatic carcinoma. The tumor extended beyond the muscularis propria. The liver bed and the liver bed margin were free of tumor, however. And a CT scan of the abdomen afterwards showed right anterior abdominal wall pneumatosis and fluid that was all likely post-operative. So, Dr. Weinberg, before we talk about the surgical choice here, not to put you on the spot, but can you give us a breakdown of the incidence and also prognosis of intrahepatic versus extrahepatic versus gallbladder cancers?
Yeah, sure. So, as you mentioned, cholangiocarcinomas or biliary tract tumors, as they're often referred to, are classified into intrahepatic, extrahepatic, and to some extent a third category, gallbladder cancers. The distribution of tumors is most commonly seen. The most common one is extrahepatic, I would say, which includes perihilar tumors, what's often referred to as Klatskin tumors, tumors arising in the common bile duct, which represents probably about 40 to 50% of tumors. The intrahepatic cholangiocarcinomas, which are tumors arising from within the biliary cells within the liver, are probably represent another 20-30% of them, and the remainder being gallbladder cancers, which are all categorized typically as adenocarcinomas. Typically, because of the nature in which these cancers manifest, and by that I mean with symptoms of biliary obstruction, certainly the most common symptom being in the case of extrahepatic, they tend to have a slightly improved prognosis over those with intrahepatic cholangiocarcinoma, which can be a little more aggressive because of the manifestation in which they present. But there's very limited data, truthfully, on the differences in long-term prognosis, certainly for tumors that themselves are all stage 4 when diagnosed. So I will mention that this is a very interesting tumor genetically, because it's among the most heterogeneous tumors that we have in the GI tract, and that while all are classified as cholangiocarcinoma and adenocarcinoma, there are very discrete genetic changes and mutations, alterations, and so forth between intrahepatic, extrahepatic, and gallbladder, which have important implications. They also, of course, have very, very different risk factors, with some diseases being primarily from Asia and being fluke associated, whereas often in the Western world can be more associated with sclerosing cholangitis or other pre-existing hepatic conditions. So overall, very, very heterogeneous group of tumors, both epidemiologically and clinically.
Excellent, thank you. Dr. Weiser, I think I wanted to ask you, and actually this is probably for my education as much as for the entire board, an intrahepatic cholangiocarcinoma would have a liver resection, a distal common bile duct would undergo a Whipple, I presume, but how does the cancer surgery differ for a gallbladder cancer from a more proximal but extrahepatic biliary cancer?
The key, of course, like any cancer surgery, would be the clear margins, and that's what the challenge is. The other part of gallbladder cancer is the recognition, of course, before the gallbladder comes out, which was done here, to make sure that you take the overlying liver to get a clear margin, if indeed the tumor has grown through the gallbladder wall. And so the other aspect is the extent to which the common bile duct is dissected for a clear margin.
Very good. So this patient had surgery. And And, Dr. Weinberg, what would be your normal post-operative or adjuvant treatment plan?
So, if I saw this pathology report and it did suggest positive lymph nodes on the basis of a cholecystectomy, I would probably send the patient, or at least consider sending the patient back to Dr. Weiser to discuss, as he mentioned, should there be additional surgery done. I really appreciate the points he made about taking adequate adjacent liver parenchyma. And, when we face the circumstance, I think the first thing we want to ask them is, has the patient had appropriate oncological surgery done? So I'll first defer to Dr. Weiser.
Yeah, I think the key, of course, is to get the segment of liver adjacent to the gallbladder resected en bloc is ideally. And then you would, of course, need to check your bile duct margin, which would be the next critical aspect.
And then as far as systemic therapy?
So usually, when we face that situation, oftentimes the surgeon will take the patient back to get those margins and the adjacent liver. And then it'll have a discussion about adjuvant therapy. Now, adjuvant therapy for cholangiocarcinoma, generally speaking, and for gallbladder specifically, is quite controversial. There is very few randomized data sets to support this, and I can think of only 2 or 3 offhand. One includes the BILCAP study, which included all patients with cholangiocarcinomas, including gallbladder, randomized patients to capecitabine versus placebo, in essence, or control, and did show a small but statistically significant improvement in survival in the group of patients in the intent to treat analysis for patients who had gallbladder cancer. So that would certainly be something to consider. And then, of course, and this is a very also controversial question, we would refer the patient to Dr. Patel to discuss the role of adjuvant chemoradiation, because there have been studies and suggestions that there may be a role for radiation. I will say that with positive lymph nodes, while not definitive, I would certainly recommend some adjuvant therapy be given in this particular patient.
Dr. Patel, do you want to take that lead?
Yeah. So, I think I agree with Dr. Weinberg. Not randomized evidence is lacking, certainly as it relates to the use of adjuvant radiation. I think we continue to rely on single-arm phase 2 SWOG trial S-0809 as our best evidence for there being a role for radiation here. So we think that the chemoradiation regimen of 5-FU and concurrent with radiation is an active regimen. In this study, systemic therapy was first. So I would certainly, I think, defer to Dr. Weinberg for systemic therapy. Gemcitabine, capecitabine, is what was used in the SWOG study, but there may be other options, as he mentioned, as a sort of adjuvant induction, followed by restaging, and then if no evidence of progression at that point, to consider adjuvant chemoradiation.
Good. Actually, if I can take a minute and go a little bit deeper on this, Dr. Weinberg, did you have something you wanted to chime in on?
Well, I completely agree with Dr. Patel. I think usually the systemic part of it would go first, and then the question of should you add radiation. It really depends, Dr. Pishvan, on the extent of the margin and the extent of the lymphadenopathy that was positive. I think these are, as Dr. Patel mentioned, we have limited randomized data, so we rely on single-arm studies or small randomized phase 2 data sets. But prognostic recurrence has direct implications to the extent of the nodal disease. So if a patient has extensive positive lymph node defined as N2 or above, I certainly would consider a more aggressive chemotherapy regimen rather than just capecitabine. And those would include regimens such as GemCape, which was used in SWOG, or alternatively GemCis, gemcitabine and cisplatin, which is a regimen often used for metastatic disease for these tumors.
Good. And then Dr. Patel, it's not really appropriate to this case, but I wanted to ask the question. It's the right disease type. So I know that there have been series looking at using proton radiotherapy for gallbladder cancers, not in the context of adjuvant therapy so much, but in the context of inoperable cancer. What's been your experience, or can you tell us anything about proton radiation therapy to that sort of gallbladder area or biliary area versus standard radiation?
Yeah. I'm fortunate to work at a center where we do have proton therapy available, and almost certainly we would utilize it in this type of a case. Really, the major advantage is related to sparing of the adjacent critical structures, and in this case, the liver is one of the most is the organ that will probably spare the best, and where you might see the biggest difference between a proton treatment and a standard photon treatment. And that partly is related to the fact that the volume, or the target volume for radiation here, is quite extensive. We're wanting to cover, all of the areas where there could be where the primary tumor may have been, which includes, a lot of the undersurface of the liver, as well as all the draining lymph node areas. And so the target volumes become large, and that's where we see a benefit to proton therapy, where you have much less unintended irradiation of the liver in particular. So with these larger target volumes, I think that's really the major benefit.
So maybe that took me a little bit by surprise. So you would use proton therapy for this adjuvant case?
Yeah, usually we would, because we just have a better sparing effect for the liver. The toxicity seems to be better. And so for most cases, we'll at least look at a comparative plan where we'll compare a proton and a photon plan. But more often than not, I'm often choosing the proton plan because of the optimal sparing.
Interesting. All right. Well, to move on, this patient unfortunately did recur, as we know. So they were treated with cisplatin and gemcitabine, as Dr. Weinberg mentioned, probably because of the more aggressive pathology on surgery. Unfortunately, did not tolerate it particularly well. We don't know how much they actually received. And by March 2021, the patient had progressive disease on imaging, with interval bilateral pleural effusions and ascites, and also thickening and dilation of the jejunal loops at the hepatojejunostomy site, along with focal dilation of the proximal loops. So Dr. Siegel, if you want to walk us through this imaging.
Sure. We have on the right a post-contrast image, and on the left we have a lung window view. And you can see here that there's bilateral pleural effusions, and that there's some bronchiectasis in the right lower lobe. Again, just reiterating that this is a bad sign with these increasing pleural effusions and ascites.
What are your thoughts on the pattern of recurrence for this resected gallbladder cancer? I feel like it's a little unusual, not unheard of, but a little unusual for cholangiocarcinoma. Do you think? In
terms of this sort of peritoneal disease?
Not so much the peritoneal disease, but the pleural disease and absolute lack of any other visceral disease.
I think it's atypical. I do. It's possible that there's a little bit more disease locally in the neighborhood of the surgical site than we know. But I would say this is an atypical presentation. Yes.
And maybe I asked that question intentionally to set up the next question, which is really for the whole panel, is do you always feel compelled to quote unquote prove recurrent metastatic disease pathologically? And Dr. Weinberg, if you want to start, and we'll go around the panel.
I don't necessarily feel that that's essential in every case. I think that, if this patient had an elevated tumor marker at diagnosis and now has continued to have an elevated tumor marker at the completion of treatment and has obvious metastatic disease, as seems to be the case, I sometimes regard it in this kind of situation as important to try to get more tissue if molecular studies can be done, if that's a feasibility. I think there is a real role to try to get more tissue.
Okay, Dr. Patel?
I agree. I think with characteristic imaging findings and sort of within the sort of window for when you might find recurrence, so maybe a disease, a shorter disease-free interval, for example, we don't always rebiopsy. Say for an excellent indication, as Dr. Weinberg mentioned, for more tissue from molecular profiling.
Dr. Weiser, how do you feel about definitively proving pathologic recurrence.
No, I would agree with the panelists and what they've said so far. It would be a little bit difficult possibly here to do that, and I think we could spare him an intervention that we probably wouldn't trust a negative biopsy anyway.
Yeah. And Dr. Siegel, as Dr. Weiser just mentioned, it's probably pretty hard to biopsy this peritoneal nodules.
It depends upon how big they are. I'd say we do surprisingly pretty well with sub-centimeter peritoneal nodules, biopsying them on ultrasound. But when I mean sub-centimeter, I mean like 7, 8, 9 millimeters. Really like tiny, almost miliary studying. We could, I suppose, core a section of the of omentum or peritoneum or possibly, but that would be a lot harder for us.
Understandable. All right. So now moving on for the patient. So they unfortunately had recurrent metastatic disease. So how would your treatment plan change? And Dr. Weinberg, how would your systemic regimen of choice change in this case? And let's actually play a couple of different scenarios. Let's say if the adjuvant treatment was gemcitabine cisplatin and the recurrence was less than 6 months after completion of adjuvant treatment.
Right. So, it's a really interesting scenario, second line biliary tract cancers, which 2 years ago we had absolutely no data or no randomized data to guide this decision. Now we've had a number of studies in the last few years which have shed a lot of insight on roles of both chemotherapeutics and perhaps targeted therapeutics as well. So this is the kind of patient where I do feel if it's possible to get some degree of molecular information either off the original primary or if an additional biopsy is necessary, it's not a bad idea to do so, because in gallbladder cancer, certainly there's a number of molecular alterations that are seen, including HER2, IDH1, which is probably the most recent one that's been of interest. IDH1 mutations are much more common in intrahepatic cholangiocarcinoma and less common in gallbladder. And finally, fusions of FGFR, of the FGFR family, are perhaps among the most common alterations seen in extrahepatic cholangiocarcinoma. Now, in the last week, actually, we see randomized data reported in Lancet Oncology in this kind of situation, which randomized patients who have second-line cholangiocarcinoma to either symptom control after GemCis, I should say, or FOLFOX. So that was the first large randomized study to show an improvement of anything, actually, after progression on first-line chemotherapy. Now, in this context, for all intents and purposes, even though the patient wasn't defined as metastatic when they got GemCis, I would regard them as having had systemic disease and would certainly discuss 5-FU-based therapy, which, if the patient's performance status can handle it, FOLFOX would be an option. If not, and they haven't received fluoropyrimidine, this would certainly be an optimal time to do so. If the patient does have one of those molecular alterations, such as an FGFR fusion or HER2 amplification, one could consider the addition of either trastuzumab or one of the FGFR kinase inhibitors, which are actually themselves having received, one of them at least, pemigatinib, having received accelerated approval in the United States.
Great. And you definitely talked about this a little bit, but just to complete the thought process, what if the recurrence was 18 months later after the completion of the GemCis?
I mean, essentially, I don't know if I'd treat them altogether differently. It certainly prognostically would have a much more important implication, but I still feel like I would, before I re-challenge, let's say, with gemcitabine-based therapy, I would still offer the patient 5-FU-based therapy because they'd be naive to that. But I'd feel better about the prognosis of that particular patient, and especially perhaps for a role for a molecularly targeted therapy, given that long disease-free interval.
Very good. All right, so I think for this good case, the panel recommendations were, first of all, to make sure that a good cancer surgery was done to capture all of the areas that could be affected by these kinds of cancers, even if it calls for a second operation. Adjuvant therapy is very reasonable. Capecitabine is really the only phase 3 proven adjuvant therapy, but for more aggressive cancers, lymph node positive cancers, using a doublet regimen is certainly very appropriate. Again, with lymph node positive disease, considering adjuvant radiation therapy is also appropriate, albeit without any randomized data to say that definitively. And that molecular profiling for recurrence or at the time of recurrence is really critical, because 25 to 40% of biliary cancers harbor some actionable molecular alteration.